it's hard to listen to this and read the literature and not generally view much of what we're seeing as a negative phenomenon. But then this little bell goes off in the back of my mind, and I remember, 20 years ago, we were maybe even 25. We were sort of saying the same thing about insurance companies getting more involved in how care is delivered, and them saying, look, these systems are terribly disorganized. There's poor information flow. We provide an infrastructure, and if we're good at it, we gain market share. And and sure, we keep some of the money, but there has to be an incentive to do this hard work. So I guess my question is, although I understand the more intensive services, there's no direct test that was in your study, Brady, about appropriateness, but moving from physicians to providers with a slightly lower level of training, but potentially all of what they need to provide the care. Containing growth in physician salaries, which is a primary cost in the healthcare sector. Is there a way? I guess really the question is some of what's happening here driving efficiencies? And we might have a debate over whose pocket those efficiency gains should go into, and that's a very good conversation to have. But is there evidence here of driving efficiencies that we might want someone to do, and we might worry that if we shut it down here, that those efficiencies just aren't going to be created? Chris, I'll let you kick off. I don't usually use raised hands in presentation in sessions like this, but it's actually working kind of well.
If we look at the landscape of integrated systems, probably the most integrated system is the Kaiser Permanente system, which is, I think, pretty or Geisinger as well, which are widely held as models for the healthcare delivery system. And so I think there's maybe, especially with insurer provider integration, there may be a bit of a tension where we're at the one hand holding up the Kaisers and Geisingers of the world, on the other hand saying that when, say, United or other insurers acquire providers, that's somehow the bad type of integration and too consolidated. I think a key distinction, though, is that when we look at consolidation right now and the types that we've talked about, it's largely clinical integration. And so we have a hospital system clinically integrating with a provider group, but we're not seeing any financial integration where the provider and the hospital system are both clinically integrating, but then also bearing financial risk for making sure that they have high quality care. And so I think there's a concern that if we're just focusing so much attention on this financial or clinical integration rather, but ignoring financial incentives, that we're kind of likely to get the worst of both worlds. And in some sense, if we pushed for more financial integration where healthcare systems were more responsible for patients or paid more in a capitated environment, then frankly the delivery system can consolidate and decide how best to organize itself. And if payments are appropriately capitated, then maybe the structure of the delivery system is less of a spending concern.
Thank you. Erin, and then Greg.
I think, in some ways, health services researchers have done a great job of studying that question of is consolidation or integration, whether it's from payment delivery reforms or ACOs or this type of vertical consolidation, is it generating efficiencies? And I think because all the providers will say when they're merging, oh, we're going to generate a lot of efficiencies, we're going to coordinate care, quality is going to go up. Same thing with ACOs, and the evidence has shown the efficiencies are just not there. So there's clear evidence of the cost increases. There's sort of mixed evidence on quality, right? Like it's sort of like not great on quality, not always bad. Sometimes it's terrible, but it's, on balance, it's sort of mixed. And then the efficiency evidence is just not there. And so I think what we're seeing is that for sure we know that this increased costs and And then the question is, where are those costs or profits? I think they're profits, really. It's cost to us, the purchasers and patients and society, but it's profits to these entities, and where are they going? And is that the best and highest use of those taxpayer dollars or our premium dollars? And that's a policy question, but I think that there is no evidence so much of the efficiencies. And so I think the question is, what's, not so much on the efficiency, but I think that the bigger question is, where are we going to get the capital? If we were to try to squeeze, the corporate sort of incentive out of the system in some meaningful way, where's the capital going to come from? So physicians who really don't want to run their own practices, maybe they don't want to be, employees in the true sense, but they don't want to run their practices and buy EHR systems and report on all their quality metrics and all of that and negotiate with payers. So where is that capital going to come from for them to be able to do that? And I think that's a good question.
Great, Greg.
I want to build on what Chris said a moment ago. As Erin pointed out, this is a complex ecosystem. Lots of different creatures in this Amazon jungle, and some of the creatures, like Kaiser, as an example, do engage in exercises of striking balance between cost and clinical value in healthcare. And we may argue about how they strike the balance. We may argue about whether it's a problem that they're not transparent about the rationing that they engage in, et cetera. And that's one of the classic health policy and ethics arguments that we've been having for 30 plus years. But there's the potential, so long as you think that the cost curve should be, we should limit where we go on the cost curve so that we don't spend on every possible benefit, however expensive small increments in benefit are, then there's space for what, Kaiser et al. Do. That is very different from this enterprise of extraction that a clinical operation engages in when it consolidates, principally for the purpose of achieving greater bargaining power vis-a-vis insurers. The practice of 2 or 3 gastroenterologists in Washington, D.C. is a price taker, right? We may object to that or not, but when Capital Digestive comes in and acquires a whole bunch of practices, as it has in the Washington, D.C. area, I believe that in excess of 60 gastroenterologists are part of Capital Digestive now. That's a private equity entity. Then it can go out and negotiate prices. It pushes those prices up. And I fail to discern where the value is for, say, healthcare payers or for patients in that proposition. That would seem to be a cost-raising process. Clearly, research documenting this intuition or disproving it is at its infancy. But I think it's important to distinguish between extraction enterprises and cost-benefit value balancing enterprises that might well have a chance at achieving the kind of value that Alan is pointing to.